She's a pediatrician neonatologist who has worked extensively on newborn and child health with WHO at global, regional, and country level. And she will be providing an overview of the standards. And last but not the least, Dr. Nuhu Yaqub. He is the Technical Officer, Maternal Newborn Child Health Quality Management with WHO Regional Office for Africa. And he will be speaking on country examples of standard implementation. So with this brief introduction, let's get going. Over to you, Ornella, for the first presentation.
Good morning and good evening to welcome to all the presenters. I'm sorry I'm not able to move the slides. I remove them again. Okay. I'm very pleased to be with you today to present the standards for improving the quality of care for small and sick newborn, and specifically the purpose of the standards in the context of our work on quality of care for small and sick newborns. Just a second that I try to eliminate some of this. So this document, standards aim at operationalize all the policy recommendations that we have presented to you in the previous webinars and are in the report of Survive, Thrive and Transform Care for Very Small and Sick Newborns. And specifically, they aim at addressing the high mortality of newborn, mortality and morbidity of newborns, and also addressing the quality of care. We know that 30 million of small and sick newborns require access to services every year, but many of them, about 50% of them, don't receive care at all, and those who receive care many times receive poor quality of care. We also know that this problem exists in high-income countries with 1 in 10 patients usually harmed while receiving care in general, not only newborns. And then we know the challenges that low and middle income countries are facing in terms of infrastructure like running water, sanitation, but also a lot of how we approach our women and our newborns, for example, exposing them to harmful procedures or even respectful care and neglect. So the standards address all this. They respond to the WHO vision that we published already a few years ago, that we of having every woman, newborn, child, and adolescent receiving quality of health services throughout their life cycle and level of care continuum. And for the newborn, in fact, the continuum of care is very important. It's a continuum across the services, so we are not thinking about only the time of birth, but we want to look at what happens before pregnancy and before birth and during pregnancy, as well as after the birth, so as well as what can be linked with not only the facility, but also linkages with the families and the communities. So the standards have, in the past, we have, as you are aware, we have published standards of care, the quality of care framework and standards of care for maternal and newborn health on the left, and for children, adolescents on the right. And these standards and frameworks are similar and are actually address the needs of different groups. And we felt the need of going more in detail for what are actually the required standards of care for the specific population of small and sick newborn. It came through the discussion we had when we were developing the report to Survive and Thrive, and we realized that there was a need of really define better, mainstream and standardize what we mean for inpatient care for small and sick newborns. Building, of course, on existing platforms and initiatives. So building on essential newborn care by going beyond that, and building on the initiative of equity, quality, equity, dignity that we are supporting together with our partners. And the idea is to actually guide countries on what can be done better in addressing the need of this especially vulnerable population that are actually the newborns who are born premature or with some complications. So why these standards were required? This is we saw that existing standards lacked the specificity required for the care of small and sick newborns. For example, the maternal neonatal standards were targeting specifically the time of birth and the first week of life with essential care, but they were not detailed enough for the complications. The WHO pediatric and the young adolescent standards were lacking evidence-based interventions for this group of babies. And then both the documents were a bit too light, we thought, in terms of what are the requirements in terms of health system if you want to set up services for special newborn care or even in so services for this population. And the other aspects that where we felt things were a bit, the documents were weak was on the experience of care as it refers to the small and sick newborn. So we started with the scoping exercise. So a big literature review and mapping of the existing intervention and recommendations of WHO and beyond WHO actually on the care of small and sick newborns. So we define what could be the inclusion and exclusion criteria for the standards of care for small and sick and their applicability also in different contexts. Then there was the phase of drafting and consultation. So drafting of the standard statement first, and 2 rounds of inputs and revisions before we went to the drafting of quality measures. Then we had the technical meeting in April last year, and then more revisions, and then an external consultation on the quality measures, and finally more discussion also internally in WHO with different departments, and finally we revise and finalize the document. We aim at launching the document next month. The conceptual framework that has been developed for the standards, you can see the same that we use for the other documents. So but we went, of course, so we are the conceptual framework with 8 standards, of which 3 are on the provision of care and 3 on the experience of care, and then we will stay more in the course of the webinars where we went more detail, and then 2 on the human resources that are required for these services for babies, and then the essential physical resources that need to be in place to provide quality care for small and sick newborns. And we highlight also the fact that these standards should be applicable to all health facilities that are offering maternity care as well as newborn care services, secondary and tertiary level. They should cover essential care for both essential care as well as care for small and sick. So you will see there are standard statements from the previous document that have been put together with the new standard statement. So in this standards of care document, you will find all what is required basically to care for newborns, essential as well as care for small and sick. The standards also wants to promote newborn and family centered approaches. And then you will see their specificity along all those areas. So, and then we ended up with 8 standards, one for each of the domains of the quality of care framework. We have a total of 78 standard statements, so 3 or more for each of the standards. The majority are under standard 1 on the evidence-based practices. And then we have, of course, a number of quality measures inputs, output, and outcome measures for each of these standard statements, like a menu of measures similarly to what has been done for our previous document and standards. So finally, these are the 8 the statements. So I want to highlight that in developing those standards, we wanted to put really at the center of care. So, and uphold what are the rights and the needs, as well as the rights of these newborns and of course their families as well. And so on standards 1 is, maybe it's good to read these standards. So standards 1 is saying every small and sick newborn receives evidence-based care and management of illness according to WHO guidelines. Standard 2 is on the health information systems, the enabling collection, analysis, and use of data to ensure early appropriate action to improve the care of every small and sick newborn. Important early appropriate action. Standard 3 is very important as well, is on the referral system. So every small and sick newborn with a condition that cannot be managed effectively with available resources receive appropriate family referral through integrated newborn service pathways with continuity of care, including during transport. And then we have 3 standards on the experience of care, so which are highlighted in some newborns actually. So communication with small and sick newborns and their family is effective with meaningful participation and response to their needs and preferences. And parental involvement is encouraged and supported throughout the care pathway. Standard 5 is also very important. Newborn rights are respected, protected, and fulfilled without discrimination, with the preservation of dignity at all times and in all settings during follow-up. And standard 6, which is focusing on linking with the nurturing care framework as well, says all small and sick newborns are given developmentally supportive care and follow-up, and their families receive emotional and psychological support that is sensitive to their needs and strengthen their capacities. And then we have the 2 standards on the system resources, very 7 on the human resources, saying that every small and sick newborn, for every small and sick newborn, competent, motivated, and empathetic multidisciplinary staff are consistently available to provide the routine care, manage complications, and provide developmental and psychological support throughout the care pathway. And finally, the standards on physical resources, saying that it is as an appropriate physical environment with adequate water, sanitation, waste management, energy supplies, medicine, medical supplies, and equipment for routine care and management of complications in small and sick newborns. And with this, I would like to hand over to Caroline, who will explain a bit much more on the standard statement and the indicators. Over to you, Caroline.
Thank you very much, Ornella, for your presentation, and welcome everybody. Good morning, good afternoon, and good evening. It's with great pleasure that I will provide an overview of the standards. Ornella has already presented the WHO Quality of Care statements, and as you have seen, we have standards for the small and sick newborn that include the provision of care, experience of care, and the cross-cutting areas. So I will now present some selected quality statements for each domain of our quality of care framework. Firstly, we have standard 1. The aim of this standard is to ensure that all small and sick newborns receive evidence-based care. So this standard guides healthcare professionals to provide this high quality care. It's for newborns who are born in facilities and those that present to facilities at other times. And what we have done here is we've separated standard 1 into 2 sections. So we have part A, which is care for all newborns, and part B, which is care for the small and sick newborns. So in total, there's a lot of information in the standard. We have 42 quality statements. Under care for small and sick newborns, we have divided our quality statements into sections that are pertinent for the small and sick newborn. As you can see on the slide, this includes issues including respiratory support, nutritional care, care for other conditions that we've highlighted that are common, clinical monitoring and supportive care, pain management and palliative care, and care and advice at the time of discharge. The other standards 2 to 8 have between 3 and 6 quality statements, so the content is smaller but still highly important. Thank you. I'll call the next slide. Next slide. So this is some examples of what the work we've done and the way it's been presented. As you're aware, WHO has already published documents with standards guiding care of newborns. So what we have done is we have either added to existing quality statements, or we have provided new quality statements where we identify gaps. For example, under the quality state, please, previous slide. Yes, standard statement 1.1 looks at infection prevention and control. We know that the small and sick newborn are particularly vulnerable to healthcare associated infections, and there's an added need for meticulous infection prevention and control from healthcare providers and from carers. And particularly in the current context with the COVID-19 pandemic, we've also placed some emphasis on the need to observe updated WHO infection prevention and control guidelines and the need to wear personal protective equipment during this crisis. An example of a new quality statement is 1.16, which looks at the identification and management of hypoglycemia. We're not advocating for all newborns to have blood sugar checked, but we want to highlight the importance of the vulnerable small and sick newborn, which really includes the majority of the babies that are admitted, those that are preterm with low birth weight, sepsis, hypothermia, hypoxic ischemic encephalopathy, inadequate feeding, babies of diabetic mothers, etc. Thank you. Next slide. Next, yeah. So this is an example of another new quality statement. So this is around care for the small and sick newborn, and this quality statement talks to jaundice and jaundice management. Jaundice is exceedingly common in newborn, and without treatment can lead to kernicterus or acute bilirubin encephalopathy with a host of long-term problems with motor, language, and hearing concerns. We know that there's effective and safe treatment available, particularly with LED phototherapy, which we're promoting, and regular monitoring of blood bilirubin levels as much as possible. It's not always, some facilities do not have blood, but that's what we would like to aim for as much as possible. Next slide. So additionally, the standards provide quality measures that can track and monitor performance in improving quality of care. And this is an example of our quality measures for the previous 1.8 neonatal jaundice standard. As you can see, it has both input, process and outcome quality measures. And under the input, we see things around the need for guidelines, standard operating procedures, equipment, particularly phototherapy, and training of staff. Under our process indicators, we look at what needs to be done to achieve effective management of jaundice, and we've tried to provide a range of different measures that the health facility or the national or subnational government can identify that they would like to look at monitoring. So you'll see a range of different things throughout the document. And then we have our outcome indicators. Outcome quality measures, which are analogous to indicators. Thank you. Next slide. This is an example of the clinical monitoring and supportive care. This is extremely important. The newborns are admitted with their specific condition and the condition is managed. But the vulnerability of these newborns requires exquisite monitoring of the clinical course, as the newborn is at risk of hypothermia, hypoglycemia, and sepsis during the course of treatment for another illness. The frequency of monitoring will depend on the newborn's condition and the severity, and any interventions that we provide should be given safely. There should be rational use of antibiotics and other medication, and safe use of intravenous fluids and blood transfusion to ensure that we're not causing any further detriment to the vulnerable populations. Previous slide, sorry. Additionally, any supportive care should only be given as required. It should not be given if it's not required. So that is an important concept that comes through this group of quality measures. Next slide, thank you. So the second standard addresses actionable information systems. And previous standards have really provided the content of the information. There doesn't need to be a lot done here. However, I'd like to highlight that often that although we may collect data on pediatric and adolescent population, often there's significant gaps in the data collected on the newborn, and this was the subject of previous webinars that were presented throughout the Survive and Thrive series. At a more level, at a health facility level, we want the health facility to record and register information on that newborn to maximise the newborn's care and quality of care in general. The medical record should also include details around the pregnancy and the delivery and the clinical observation chart with the frequency of monitoring clearly documented to make decisions on the day-to-day management. And then there needs to be a link with the national or subnational data collection systems for policy and planning purposes and to guide future quality improvement initiatives and improving health outcomes. And then finally, we want to emphasise the inputs of the families and carers in their perception of the quality of care. Next slide, thank you. Thank you. So this standard addresses the functional referral systems. In a well-functioning system, care for small and sick newborns is provided across different levels of a network of facilities organised by population size and need. We know that from high-income countries that there's strong evidence that referral of the high-risk newborn to higher level centres with appropriate resources and staff to address the required increased complexity of care have improved outcome for the newborns. And at the simplest level, this is organised across 3 levels, and this again was presented in previous webinars of the Survive and Thrive series. So the primary level, the secondary level, and the tertiary level. And these all need to be linked in through an integrated, interconnected communication and referral system, and ideally an integrated maternal and newborn network, because we want to keep the mother and newborn together during the hazardous time of referral. The standards also strongly emphasise the need for experienced staff with specialised transport vehicles. There's evidence, again, that outcomes for paediatric children and newborns have improved when you have specialist teams transporting newborns. However, we recognise that in the absence of this, or when this is not necessary, that the newborn is transported with the mother in the kangaroo position, both between and within facilities. We know there's multiple benefits of kangaroo mother care. Many health facilities in countries may not have a really sort of efficient newborn transport system. We would like to promote that, but there are lower level approaches that are safe and effective for functioning referral systems. Next slide, thank you. Thank you. So this slide looks at effective communication and meaningful participation. The standards strongly emphasise family and patient-centred care, KMC, culturally effective care, and family-based education. Quality statement, we've augmented what's already there. So the first few quality statements of the standard are already existing, but we've augmented this through quality statement 4.4, which looks at interaction with the newborn. Contrary to beliefs that used to exist, the newborn has an identity with feelings and emotions. The newborn can communicate and respond. And carers and staff can learn to identify how babies respond to them through being able to the newborn behaviour and the newborn cues. So this is what this quality statement discusses. Quality statement 4.5 looks at communication with carers. This is crucially important. Carers have often felt disempowered by the whole special intensive newborn setting. We really want to emphasise that carers are informed and are part of decision making. They're provided with counselling and education throughout the care pathway and also on discharge. And they need a clear discharge plan before the baby is sent home. And finally, quality statement 4.6 speaks to the need for effective communication and addressing fear and misinformation in humanitarian and fragile settings, including pandemic situations, of which we currently have with COVID-19 and which we've also discussed throughout the various webinar series. Thank you. Next slide. Standard 5 looks at the rights. The Convention of the Rights of the Child ensure that newborn health is a human rights issue. And this has been further articulated through other documents, including the Declaration of Barcelona, Parma Charter. More recently, in 2015, the Abu Dhabi Declaration for Every Woman, Every Child, Everywhere. And then more recently, in 2019, the Respectful Maternity Care Charter. Two really new concepts here. These are of birth and death registration. So 5.5 looks at the birth registration. We know that the right to a name and a nationality is well recognised, but still many births remain unregistered. However, in contradiction, many neonatal deaths and the majority of stillbirths are not registered, and these babies have no death certificate. This is an important for looking at quality of care in general. So we want to support carers to register newborn births, deaths, and stillbirths. Next slide. And next slide. So this standard 6 addresses our emotional, psychosocial, and developmental support. The quality statement 6.2 and 6.3 focus on KMC and developmental supportive care. We've highlighted the KMC and its importance. Where there's strong evidence of the importance of KMC, there's more evidence being published all the time, and this is a big part of our standards document. We want to highlight that mothers and newborns should not be separated, and we want to promote rooming in to promote breastfeeding, attachment, and parental empowerment. KMC needs to be supportive throughout the care pathway, and KMC is the core of our developmental supportive care and family-centred care, which you've heard about in our other presentations in the webinar. Quality statement 6.5 looks at follow-up and the importance of multidisciplinary follow-up. We want to promote early intervention to improve cognitive and social developmental outcomes of this vulnerable population. The small and sick newborn are at risk of more long-term developmental problems, which can run from quite minor problems to major cognitive problems, and then other behavioural educational problems. We want to promote ECD, or early childhood development, to try and mitigate these effects. And follow-up visits should be encompassed, and this is covered in this quality statement, with monitoring for general health, both anemia, developmental review, vision and hearing assessments, and carer support. Again, this is very vulnerable time. The carer has a lot of needs, mental health needs, and will require support and maybe further intervention for themselves. Next slide. So this is just another example of our quality measures, and this speaks to the previous quality statement looking at developmental supportive care. And again, as you can see, it's a similar format, our input in terms of our guidelines, collecting of data, staff training, and the process of what needs to be done to achieve adequate developmental supportive care. And then we have outcome quality measures that can be looked at. So we move on to standard 7. So we know that small and sick newborn survival in facilities is linked to the number of qualified nurses working per shift. Previous WHO standards have spoken a lot about the need for human resources, but we have tried to make this more specific for the needs of the small and sick newborn. Often there isn't a specialist cadre of neonatal nurse specialists. That's something we really want to promote. And even if nurses are working within neonatal or special care units, they're often moved to other parts of the health facility. So in this case, we lose their mentoring for junior staff, supervision, and the quality of care. So we want to avoid that. We also want to ensure that nursing staff, in the absence of medical staff, are authorised to provide important interventions, for example, administration of oxygen, antibiotics, because the situation is often quite critical and interventions need to be provided quickly. And then at the health facility level, we really need strong managerial leadership and advocacy and supportive policies that can ensure the workforce is available to provide high quality care for the small and sick newborn. Next slide, please. And finally, Standard 8 addresses our essential physical resources. So essential physical resources for the small and sick newborn require that the facility is prepared, so-called service readiness. Our previous standards have provided a lot of information on what is required, but there are some special areas for the small and sick newborn in terms of designing newborn services according to the standardised level of care is very important. Making sure that we have equipment of the correct size and specifications, highlighting the need for maintenance of this equipment. I've been in many newborn nurseries that have a room that just has an old graveyard for old equipment. So because the staff have never had any information or support to have the equipment maintained. And then we require a supportive environment in terms of space to provide appropriate care, hand washing facilities, temperature management, attention to light, noise, vibration that newborns are very sensitive to. We also have a quality statement that speaks to the physical environment for KMC, which is extremely important. Without a supportive physical environment for KMC, it's very difficult for mothers and families to provide adequate KMC. These facilities need to be fully equipped and with a close attention to hygiene and staff that are very supportive. And then finally, we have introduced a quality statement around the resources required for the humanitarian and the fragile setting. The newborn priorities should be clearly raised in discussions and coordination for humanitarian settings. And this should be linked in with maternal needs as well. And they should be also integrated into longer term preparedness and resilience buildings in the emergency response to try and mitigate long-term impacts of the crisis on women and children. So I'd like to finish there and hand over to my colleague, Mr. Nuhu Yacob, who will present some points on implementation. Thank you very much.
Thank you very much, Caroline. So as Caroline said, I'll be presenting and just give sort of an overview and summary about how countries have been implementing the previous standards, the maternal newborn health standards and the child health standards. And this will be based on the experiences and learnings we're seeing from implementation in the network countries, in the quality of care network countries. Next slide, please. Thank you. So Ornella has already talked about this framework, which was developed in 2016. So I wouldn't want to spend much time on it, but just to say that, and as well as Caroline also did, to say that the framework touches on both provision of care and experience of care, but also does emphasize that in terms of providing quality of care, you need to also take actions in the foundational elements of the health system. And so with this said, we've begun to think about how can we begin to take forward the standards in terms of implementation and how to demonstrate how they can be used. Next slide, please. Next slide. So to take forward implementation of the standards, in 2017, the Network for Improving Maternal and Newborn Child Health Quality of Healthcare Services was launched in Malawi, and it is a broad partnership of governments, partners, agencies. Although housed by WHO, it is country-led and it's been put together such that the emphasis on how can countries begin to take forward. It's starting with the maternal newborn health standards, the child health standards, and now these standards. And broadly, it's looking at it began initially with 9 countries, but 2 other countries have since joined: Sierra Leone in 2018 and Kenya last in 2019. And the overall vision of the network is to accelerate maternal and newborn reduction of mortality for maternal and newborn deaths in health facilities by 2022. Next slide, please. Thank you. So the approach for the network that the network is working on has been to through the identification of 4 areas of work, how to take forward this work. The first is leadership, which is to build and strengthen national institutions and mechanisms for improving quality of care. So this takes into account all the work around the policies and developing policies and strategies, developing operational plans, and also making sure that the health system at a different level is organized in such a way to be ready to support improving quality of care. The next is around all the work that take an objective around strengthening the capability, particularly at point of care and health facilities, to implement the standards themselves and also other quality of care packages to improve care for mothers and newborn. The next objective was on learning and a huge emphasis around the use of data to drive improvement, but also not only that, but also to begin to think about making sure that learnings that's coming out from health facilities and other parts of the ecosystem can be translated and spread to other health facilities, to other districts, and eventually to other countries. And the last objective is a focus on accountability, where also not only bringing and producing a transparent manner, but also making sure the community is involved in not only participating and receiving services, but also having a voice in terms of deciding what is quality and how being engaged for quality. Next slide, please. So the results framework, I wouldn't want to get so much deep into it, but it does show that the vision, which is around making sure that every mother and newborn receive quality care through pregnancy, childbirth, and in the postnatal period. And it is based on the values of quality, equity, and dignity. So without getting into much details, about it is just to highlight that under each objective, there are a number of output actions which have been identified as strategic and important in order for implementation of standards. As I said in the previous slide, the work around governance, leadership includes work around governance and work around mobilization around a harmonized agenda. That around action is looking at the standards and also the clinical managerial support that are necessary to implement the standards. Around learning, you think about data systems and also data practices, and around accountability, looking at how can you, what mechanisms are available at country level in order to drive accountability and make sure that the community is involved. And all of this is based on a vision where it's government-led, it's based on government strategies, it's not a separate strategy, it's based on the quality of care or the maternal newborn child health strategy, but with partnership and implementation support from not only WHO, but other implementation partners, UNICEF, and also academia, civil societies, and donors. Next slide, please. So I'll just go now briefly into just some specific things we are learning about implementation of standards. Next slide, please. So overall, we've seen that countries have used the standards, the maternal and newborn health and literature in 6 main areas. 5 initially, and the 6th one is one that we are beginning to see. Now, the first is around countries that use standards around guidance in terms of organizing health service delivery, identifying how which health worker competencies are needed at different levels, how services should be reorganized to make sure that it's fit for quality care, or including standards either as standalone evidence-based national standards or integrating into more composite standards which cuts across all disease programs. Countries are also using the standards, like for example in Tanzania and in Ghana, as part of assessments, benchmarks, and audits, that routine audits that take place. And the standards are used to set for maternal and newborn health to set what the benchmarks are. Also, in Ghana, we've seen that the standards have been integrated into the health insurance accreditation process, such that even when private health facilities are interested in getting reimbursement from the health insurance services for maternal and newborn health services, they're accredited against being able to provide quality care against the maternal and newborn health standard. And finally, and as Caroline said, we're beginning to see that as the COVID-19 outbreak evolves, countries are going back to the standards in order to set quality care to ensure that to minimize the transmission of the infection both to pregnant mothers but also to health workers. Next slide, please. So what are we learning? I think first of all is that it's really, really important to bring together, and this is the next step in terms of both these standards that Anel and Caroline have just spoken about. How beginning to think about it is to very early on to bring together a coalition of partners, not only for maternal and newborn health, but from other directorates, because the standards, as you have seen, cuts across. It's not limited to maternal and newborn health. It has implications for health information system, human resource for health system. So right at the initial stage, bringing together this coalition of partners to think about what might be the different bottlenecks that that might hinder the implementation of the standards. As I said in the previous slide, countries also are one of the ways of ensuring sustainability is to integrate these standard statements and measures into overall national quality standards that cuts across different areas. Begin using the standards in districts. In the network countries, this have been called the learning districts. So beginning to think about, test them and see how they are being implemented, understand what's needed for implementation, and use that to inform scale up. Ensuring that even as you begin to implement, that there is support, whether it's in terms of mentoring or coaching at facility level for health workers. And finally, I think huge emphasis around, as quality, without data, you can't improve quality of care. So it's to talk about very early on in the process, looking at how you can improve data systems to ensure that the measures, whether it's at facility levels or more composite measures at district and national level, can be captured through the health information system. Next slide, please. So some of the challenges we have seen in terms of implementation, and this is something we should take in mind, is that we have seen that sometimes the adoption or adaptation process has been somewhat lengthy and it has taken some significant time, and this results from a number of issues, including building the right coalition of stakeholders, where in the implementation planning cycle the country is. But however, these are things that if there's a good start initially with engaging with broad coalition of stakeholders, most of the countries who have moved the fastest have used that as a way of overcoming this bottleneck. And also resource availability has hindered implementation in some countries. As I said, around data, one of the issues is many of our health information systems are not built to collect quality indicators. So that's something that as you begin to implement, to think about that from the start and also begin to do some work around what are the right indicators that can be collected, what's being collected now, what can be collected through the existing system. And finally, how do we engage the community, not only for them to participate, but also actually importantly, how do we assess those measures or standards that are around provision of care? Next slide, please. So ultimately, I think local context will determine and shape how you design implementation and introduction of the standards, and also understanding of what the needs are. And there are a lot of things that are happening at country level, and therefore this new small and sick newborn standards, which are coming and should not be taken in isolation, but should be taken within the context of other what's happening around. But I think some ideas are moving forward would be to already, particularly for the network countries, but for countries beginning to engage with the technical working groups, how looking at the process of where updating of the maternal newborn health quality of care roadmaps which already exist, but to include not only activities for the sick and newborns, small and sick newborn standards, but also for child health. Also to understand that already there are established quality of care, point of care structures at facility level. So how do we begin to put this and integrate this into this? And also huge emphasis around documentation and sharing of lessons, sharing of experiences in terms of to both shape learning, but also to I think to also understand how to use community platforms better. And finally is to say is that although I did say that existing data systems might have challenges, but I think within still that context, there are some indicators that can already be collected and be used to begin to track implementation. So in my final slide, I would just want to emphasize from the network, particularly what type of support we can provide. We have developed an implementation guide for facility and district and national level around MNCH quality of care implementation. We can provide support around policy dialogue. There are lots of technical people, including Onela, Dr. Guga, Caroline, around adaptation of the standards, developing the implementation package of building capacity and use of the standards. We also have a measurement handbook around how you can select data, which you can access on the website. We will also be launching soon a guide on how to engage the community in terms of implementing the standards. And we do have our community of practice, and which you can access through the where you can also learn from other health service providers and other health managers in other countries, which you can access through the quality of care network. And overall, as with a huge emphasis on our national doing everything within the context of overall quality policy and strategy, there is a quality of care handbook which takes you through the process around developing quality policy strategies so that all quality initiatives are anchored within this. So I'll hand over now to Onela for the last slide and we can end.
Thank you very much. So just briefly to let you know that These standards we are planning the launching in September, probably on the 3rd of September. And then we, of course, we are ready to support our quality, equity, dignity countries to incorporate the standards in their programs. But also we are keen to support additional countries that are ready and interested in expanding services for small and sick newborns. And then the other part is to let you know, move also to the promotion of the standards of care through other channels, like, for example, through education programs, in order to strengthen the human resources. So I would like to stop it here and over to Seun for the answers.
Thanks, Ornella, Nuhu, and all the panelists for providing us with the glimpses of the standards of care for small and sick newborn that are being released next month. This will be much needed as we now direct the action and support at country level where the actual need exists. And scaling up the quality care for small and sick newborn will definitely need the physical, financial, and human resources, but will also require the technical know-how of how to do so. And this is what these standards will actually contribute to. With this, we will now take some questions, and for this, I'm handing it over to Dr. Rashmi Mathur. She's a pediatrician and consultant with WHO Geneva. Over to you, Rashmi. Rashmi, you're muted. Yeah.
Thank you, Dr. Gagan. We have just around 3-4 minutes for the question answers. So starting with the first one, it's for Dr. Ornella. How do the standards for experience of care get affected due to COVID pandemic? And how do we titrate it to different socioeconomic stratas of society?
Well, I think the principles that we're promoting through the standards of post-mortem sick newborns can be applied also to the, and should actually applied to the COVID pandemic situation as well, in the sense that we need to use evidence-based practices, and we know that sometimes because of fear of COVID, not evidence-based policies have been put in place in some countries, so that the standards can help to reinforce that. And then we need data on COVID as well, newborns and mothers. And then we need the IPC. So I think the standards can help also in that sense.
Thank you, Dr. Ornella. The next question is for Dr. Caroline. Given that the need of small newborns and sick newborn may be different, are the indicators or measures somehow differentiated for the two when needed? This will be especially important at the lower health facility level to ensure proper capture of data for sick newborn and small newborns.
Thank you, Rashmi. I understand that there's going to be more clinical guidelines published by WHO on the care for the small newborn. So updating based on more recent research for care of the small newborn, and that encompasses a lot of the issues that are pertinent to the small sick newborn. There are other intervention required for the sick newborn, not so much the preterm or low birth weight newborn, and they have been covered not completely by WHO, but in other obviously evidence-based publications and textbooks on newborn care. So the process is an evolution. We have the WHO have a quality of care sort of implementation strategy that has the standards, but also has other derivations, including guidelines and implementation approaches. So it's a sort of process and evolution, I would think, unless Ornella wants to add anything else at this time.
Fine.
Thank you, Dr. Caroline. Our next question is, what about why we must bring antibiotics after birth? Why we must bring antibiotics after birth?
Sorry, Rashmi, who's this directed to?
It's not directed to anybody, or any of you can take it, please. Maybe Dr. Caroline, you can take it over.
Sorry, why antibiotic after birth?
Yes, why we must bring antibiotic after birth. This is what is written exactly.
Okay, so we're not recommending that all small and sick newborns receive antibiotics. Antibiotics are required, obviously, for newborns who have sepsis or at risk of sepsis, and we have guidance of what encompasses that group of newborn. There are some very small preterm newborns that often we will provide that cover initially, but that's really often in a neonatal intensive care environment. We're certainly not advocating that all newborns should have antibiotics.
Thank you, Dr. Caroline. One last question that I will take for Dr. Nuhu is, do you have some of the quality indicators that can be added in the HMIS tool for tracking and monitoring purposes?
Thank you, Rashmi. So at the moment, we have quality of care indicators for maternal and for maternal and newborn health, but early neonatal care. We have begun the process for both child health and eventually also for this to begin the process of around selecting quality of care indicators, and that will go through a WHO process. However, I do want to emphasize that at country level, already some countries are already collecting some of these indicators, but the best approach would be to, together with other stakeholders, sit down, look at what's already collected in your health information system, think of and look at what's your overall aims. What does as a country the aims around quality of newborn sick and small and sick newborn quality of care, and also you can be while at WHO we're developing the overall global indicators. At the country level, you can also begin to look at indicators, and those learnings also will inform work that's taking place both at regional and global level.
Thank you,
If
Dr.
I may add, thank you, Nuhu. I would like to say that there is an ongoing discussion actually on the indicators also for small and sick newborns. And then we are reviewing a bit, we are planning to review the exactly along the line, what is his experience, what is available along the lines, there's what Nuhu explained. And all this will converge in a meeting that we are planning in November to discuss the neonatal indicators, enough indicators as well as quality of care indicators. So I remain tuned on that because the conversation continues.
Thank you, Dr. Onela and Dr. Nuhu. Due to time constraints, we'll not be able to take the rest of the questions, but we'll surely post the answers for all these questions on the website of Global Community of Practice for Quality of Care. I will send the link to the website along with the link to the presentation and the recording of the webinar to all the participants through an email. And I will also, this recording and of the webinar and the presentations will be available on qualityofcarenetwork.org, as is the previous 6 webinars. Thank you, and over to you, Dr. Gagan, for the closing remarks.
Thanks, Rashmi. As we conclude, the message is loud and clear. With more than 60 countries currently off track to meet the SDG target for neonatal mortality, and the macro data from countries clearly showing COVID-19 is indeed impacting both the coverage and quality of inpatient care, be it the institution delivery rates, the C-section rates, or the special newborn care. The lives of millions of small and sick newborn truly hang in balance today. With this, we reach the end of this fascinating series, and before we sign out, I would like to thank all the panelists, as well as Dr. Rashmi, Shehu, and Benedict for doing all the heavy lifting behind the scene to bring it so seamlessly to all of you. Thanks also to the 100+ newborn champions who could join today's webinar. We will be now taking a pause for a few weeks, and we'll be back with more action in September. And this time, as Ornella said, with the launch of ENAP targets for the next 5 years, and the release of standards for small and sick newborn care. So stay tuned, as they say, for more of the new normal. Thank you.